डॉक्टर महांती कहाँ गुम हो गया? और इधर ही है, आ जाओ आ जाओ आ जाओ।
I would request the chairpersons to conduct the second technical session. Thank you.
You had a vivid talk in the previous session about the incidents, where are the trauma centers, communication, and all this. In the previous, and this session is basically on pre-hospital care, peripheral management at AASNS survey, and various sessions on TBI and evidence-based guidelines. There are 3 speakers. The first speaker is Dr. Leong. May I request Dr. Leong to... I'm sorry. Yeah. I'm sorry, I apologize, Dr. Riley. Can I request Dr. Peter Riley from Australia to speak on peripheral management, the AASNS study, survey, various cases, seminars on TBI. Dr. Riley, yeah, sorry.
So I'd like to talk on the pre-hospital systems, which is to say dealing with that period of between the time of the accident until the time of reaching definitive treatment. What in that earlier diagram was referred to as the second delay. The person, the victim, has received treatment, or there may be a delay in seeking it, but is now getting to hospital. What are the systems available? What are the problems with them? We're talking about in this diagram, that pre-hospital phase of injury, where 50% who die will do so. 50% will die within 2 hours of injury. And it's estimated in a number of studies now that 40% of pre-hospital deaths are preventable. They depend upon the provision of adequate pre-hospital treatment. It is a time where there is the primary injury. We're well aware now of the distinction between what's primary and what's secondary. The primary injury is at its maximum, but the secondary insults, those additional effects, hypoxia and hypotension in particular, can make a crucial difference to whether or not the victim will survive and in what sort of state they will survive. In a trauma care review published just earlier this year, Wesson and Kwong noted that in many places there was an absence of integrated trauma care systems. We've heard some exploration of this concept in the earlier presentation by Dr. Mahatra, that the system needs to be integrated with the pre-hospital and the acute hospital care, and that there need to be good data systems associated with it. Pakistan, it said in this study 2 years ago, only 4% reached ED by ambulance. And so it is that period between the accident and receiving the definitive care that we are concerned about. In 2015 to earlier this year, the AASNS conducted a neurotrauma survey which focused on the pre-hospital phase of treatment through to acute care. It looked at all admissions to hospital came in over consecutive admissions over a 1-month period. Data was entered onto the AASNS website, and I'll show some of this material now. The hospitals that took part are listed there in India, in Indonesia, and in Pakistan. The cause, and I've listed the 6 participating hospitals in these bar charts, and I hope you can read that more clearly than I can, but the top bar indicates that the majority of accidents were traffic accidents. The grey bar lower down in each of those represents falls, and you can see that that is the second, but by far much the second lesser cause of injury. The genders in each of these places were, as usually, the male predominated in this violent event, and the cause or the vehicle was in each place predominantly the motorcycle or moped, and that's in some places, except for Peshawar, where the motorcycle was the motor car rather, which is the top bar in Peshawar, was the dominant cause of injury, reflecting presumably the distribution of vehicles on the roads. That interestingly, and I haven't looked into more detail as to the components of this, but that extracranial injuries were recorded frequently in many centres, and particularly in Jaipur, Medan, and Denpasar. That looked at the use of helmets, and in most places this was less than 50%. In 2 of the Indonesian centres, it made just over 50% that the motorised 2-wheeler drivers were in fact wearing helmets. The question then was, who actually is the first responder? Who is it that provides emergency care at the scene of the accident? And in every place it was a member of the public. How do they get to hospital? The top bar represents ambulance, and the next bar down, the blue bar, is private vehicles. And you can see that ambulances were the lesser of the transport mechanisms in most countries other than Surabaya and Jaipur and Medan. But more importantly, perhaps, or as importantly anyway, who was in the ambulance? Who accompanied the patient? And was there was there a nurse or a doctor with the patient? And in most places, the answer was yes in the top bar, and as you can see, the answer is no. It's the predominant answer in most places. I just noted the time to hospital, which I haven't analysed in all the other places, but in Peshawar, where many of the victims will come from across the border in Afghanistan, some were delayed by more than 5 hours. The GCS on admissions, the majority were mild to moderate, which is what might be expected, and also what might be expected that those that died were more often in the severe GCS on admission category. So this survey needs to be analysed in more detail, and it will be, and in due course published. But it has its limits, like most epidemiological surveys. But it does, I think, give a window into treatment in these middle-income countries. That the limits are that it only dealt with major neurosurgical units. The pre-hospital information is limited. And the outcome data at this point is minimal. There will be a possibility of 6-month follow-up, but I don't expect that will be very detailed. But there are some points that might be raised in question about pre-hospital care that this brief survey points to. We might ask ourselves, what is the ideal pre-hospital care? Well, ideally one can say, well, rapid response by trained personnel is a minimum, and that then is followed by or accompanied by safe transport to the hospital in the shortest possible time, and that there will be guided by protocols which have been agreed upon by all participants. But in fact, as this survey showed, in developing countries, the first responders are not trained ambulance, but the public, and that in surveys done by Dr. Roy, who I indicated to earlier, that from Mumbai, that the Good Samaritan passerby was the predominant person, was commonly the person who responded first. In other words, took some action to help the victim, that they might have been helped by police frequently, and that they often were taken to hospital by taxi. The question of layperson training, the first responder, who by the roadside can do something to prevent that secondary injury, which might be relatively easily prevented by preventing choking, by preventing hypoxia, by stemming bleeding, preventing hypotension at that acute first aid level. Basic training by first responders who are likely to be near the accidents has been undertaken in a number of places to try and leverage, as it says, existing resources. And Khaleesi set out what might be the requirements of layperson training in lower middle income countries. And Roy and others from Mumbai again looked at the pre-hospital care for the injured. This is not just neurotrauma, but all injured by the roadside, and emphasised again, attempting to reinforce the existing networks of informal providers, taxi drivers and police. And this could be the most cost-effective way in a culture where sharing and helping others is not just desirable, but necessary, as they said, for overall economic survival. Layperson training has been undertaken in a number of countries. In Cambodia and northern Iraq, local paramedics and first responders were trained to provide field care, and they found that before and after introducing this system, mortality from trauma fell from 45% to 15%. In Nigeria, a training program for commercial drivers, first aid, basic first aid. And Dr. Sinha and your colleague in Jaipur has for some time had a program of training, teaching shopkeepers on the main roads first aid, main road where most of the neurotrauma in Jaipur was occurring. And similarly in Jodhpur there is a 2-day training course reported on 2 years ago. The WHO considers that trauma care can be improved considerably by having some form of checklift. In other words, that there be guidelines to assist in the management. And we are well aware in neurosurgery of the effectiveness of the guidelines that published by the Brain Trauma Foundation in America. And these include guidelines for pre-hospital management. In Australia, we have a simple system of practice-based guidelines, which we published about 15 years ago, specifically to assist the rural doctors who might not come across neurotrauma frequently, but when they did, needed to be able to respond effectively. And this support of local surgeons, which is a matter which was brought up in discussion in the previous talk, in Australia has these elements, and I think these are applicable generally, that if in your trauma system you wish to include And I think that in many places this is necessary because, as was pointed out previously, there is a great lack of neurosurgeons to provide this effective primary care, and this is a lack which isn't going to be rapidly filled. Then training is necessary. As in our program, we have rural surgical training, which involves e-learning, workshops, regular workshops. It involves feedback, and it involves, in the event of an emergency, active communication by teleradiology, something which will be addressed later in the program. Skype, for example, virtual surgical assistant, you might call it, and guidelines, which so that everybody is working literally off the same page, that the receiving hospital, the hospital will receive the patient after the acute surgical care at the peripheral hospital, and the surgeon are all working together. The decisions are made together. That there will be a level of local expertise that enables this to work, and there's a level of communication which makes sure that it's properly applied and effectively followed through. And so, in any country, I would suggest that developing a trauma system, developing effective pre-hospital care requires the data. We talked about the importance of good epidemiological studies. It implies looking at the geography. What are the specific problems in transport? They might be the roads, the delays in the roads. In Australia, it's distance and rather than roads, distance and time, and in resources, and to maximise what is available in terms of personnel and equipment, and that this can only effectively work, I believe, if there are agreed protocols, and that the resources are used effectively. And the photographs that I show at the bottom I took in Vietnam and Ho Chi Minh City some years ago. Lack of intensive care unit referred to earlier. At that point, the decision by the neurosurgeons was to drain CSF in head injuries as a part of treatment of diffuse head injury into a bag, that the family were used to assist in ventilation. So, using the resources that are available to the best of one's ability. I have to introduce the international cooperation. The gentleman in the middle, who may or may not recognise as one of our Prime Ministers. They change fairly regularly at the moment, and so you can be forgiven for forgetting, but that was Mr. Tony Abbott, Prime Minister at the time, and he is announcing a research program to address trauma and between Australia and India. And this Australia-India Trauma Systems collaboration introduced some years ago. So I think that there is a lot to be gained by collaboration, by sharing experiences, and I hope that sharing some of the experiences of Australia with the experiences that say that survey introduces may be of some value. Thank you.
Thank you. There may be questions. You could wait. It's open for some questions from the audience, and question or comment will be brief. Please. Anybody? Yes.
Pediatric head trauma research. So, how much, in 20 years time, you have got achieved 50% reduction in head injury, or what is the like?
Of the fall in head injuries?
Yeah.
Well, from traffic accidents...
What is the change in every aspect? Incidence, pre-hospital care, is it significant to cut down by 50% or so?
The incidence sorry, the incidence of what of overall head injuries in Australia on the road.
Yes.
Yes. Well, it fluctuates, but overall, over the recent decade, it has fallen by about 5 to 7% per year, my understanding. And
yes.
There's some studies, not recent ones, of the effectiveness of pre-hospital management systems, which indicated an improvement in outcome with an organised pre-hospital management system.
Can I have one more question?
Yeah.
See, I understand in 2006 in the World Trauma Conference, there are 5,000 surgeons, trauma surgeons, or something like that, and the paper published in International Neuro Trauma Journal by Professor Raj Kumar, and he said there is no breakthrough in the trauma in the last 30 years. And this is published in June 2002 or 3, I suppose. Do you think anything has been new in last 10 years or so in field of trauma?
In the management of neurotrauma?
Right.
No, I think that I referred to a couple of studies in my first talk, which indicated that there had been an improvement. This is for people that reached to a level 1 trauma centre. That there was an improvement from about the 70s to the 90s. Each year there was an improvement recorded in the published data. And this coincided, as I said, with the CT scan, ICU and Icp monitoring and so forth. But since the 90s, there hasn't been any change. So I think what we're looking for is the new breakthrough in the management of primary head injury. We can deal with clots, we can deal with, to some extent, with brain swelling in a mechanical way by ICP treatments, medical treatments, and maybe decompressive craniectomy, which we'll talk about later. But there hasn't been any fundamental change in the management since for the last 20 years or so.
Thank you. As somebody, yeah, please, Tripathi.
Couple of questions. One is, do you use this 23.4% hypertonic saline in acute raised ICP? The Americans, they seem to be very happy with it. 23.4% hypertonic saline.
Well, can I leave that until we've got some presentators later that are talking about ICP management. If I could rather defer that one to them. In my experience in ICU, which is now a bit past because I'm no longer in active clinical practice, we were using, or our intensivists were using mannitol or hypertonic saline, 7% hypertonic saline, and they would do that depending on the electrolytes, and there wasn't a clear consensus in their eyes as to which was the better. But I'm not aware of such a high concentration of hypertonic saline.
What's the formality of picking up accident victims on the roadside in Australia? Is it same as in you call a 911 number and then is that the response? Because I try to compare the CT we adopted. I was telling you earlier, Calcutta Accident Rescue. So it's usually the police who calls us, the call center.
Yeah.
And then the ambulance is actually parked nearby and reaches the place within 12 minutes. Is it similar or?
Well, I think these days almost every member of the public has a mobile phone and knows the emergency number, and that gets straight through to the emergency services, which will be the ambulance, the police, as the basic ambulance services, and maybe it may or may not be the fire engine as well. But so it's very quick from the emergency number and straight through to the ambulance service, and so they expect to be within the city at any rate, to be at the accident site in Adelaide within about 10 minutes.
Thank you. I think somebody else should ask. Anybody below 50 years age, please come up. No, it's where all superannuated people are talking. Anybody? Come on.
It's ambulance doesn't make difference. We have experience in two states of India. There are ambulance in UP without proper equipment. And in Gujarat, to improve the healthcare delivery, they purchased ATLS ambulance, which cost in Indian standard 16 lakhs rupees, to ordinary ambulance which cost 2 lakh rupees. But they had instruments like monitor, ventilator, ambu-bag. There was no technician and nurse. So ambulance is not the only requirement for improving head injury. There may be 10 minutes ambulance, but the man dies in ambulance or respiratory arrest.
Yeah.
So the question is that we have to understand head injury management is a teamwork of technician, nurse, equipment, ambulance, and time. I don't talk about golden hours, I golden minutes, because 3 minutes enough to kill somebody with a respiratory arrest.
Sure.
So the question is that there is an audit for the CAG. All the ATLS ambulance 150% in Gujarat were not utilized because there was no technician in ambulance or the nurse. So who is going to intubate and the patient got a respiratory arrest on the way? So it's a teamwork of ambulance, equipment, manpower. That is what I kept on stressing in my lecture.
I think that is our problem. We should solve it. Yeah, that's our problem. Thank you. Yeah. See, Dr. Lilly, he has really explained everything. Pre-hospital care is the most important one. And in our country and in the state of Orissa, some work has been started with 108 ambulance available. The moment you ring up, the nearby ambulance comes. Then they have people to manage such cases. And secondly, as you said, sir, about involvement of the public, which is most important, involvement of the public. I think we are just starting and we'll keep it up, pick up in short time. With this, I thank Dr. Lilly for his nice talk and audience for response.
Thank you. Now may I invite Dr. Erki Sueheru from Japan, who will be enlightening us with this talk, evidence-based guidelines for pre-hospital and acute care in Japan. Dr. Erki Sueheru, please.
Hello, my name is H. Suehiro. I came from Yamaguchi in Japan. Today, I will talk about evidence-based guideline for pre-hospital and acute hospital care in Japan. As you know, so in treatment of TBI patients, so it's important to prevent secondary brain injury. And for that, so pre-hospital care is very important. So secondary brain injury it begin immediately after trauma and occur on both so microscopic cellular level as a result of hypoxia and macroscopic level like subdural hematoma compression. And further, so secondary brain injury determine patient outcome and it can be prevented and controlled with good management of pre-hospital care. Pre-hospital treatment. It's important to spinal precautions and airway management and oxygen supply to maintain oxygen saturation. And normal breathing should be maintained. And maintain blood pressure. Maintain blood pressure. Keep over 90 mmHg. This is for prevent secondary brain injury. In Japan, from 2003, Japan pre-hospital trauma evaluation and care started. It's a guideline for pre-hospital care and educational course for ambulance and the nurse and the doctor. This guideline for evaluation and care quickly at pre-hospital. We call this Jtech. So Jtech protocol is first, a head should be fixed in neutral position for preventing spinal injury. judgment should be performed within 15 seconds, whether danger of the life is tangible or not with initial evaluation. Initial evaluation is we evaluate initial evaluation with consciousness and normal breathing, BP, blood pressure, maintenance or shock. And third, when there is abnormality in the initial evaluation, leaders, it means ambulance leaders declares load and go. Load and go means perform the treatment essential for life support. So securing the airway and ventilation and for prevent hypertension. So it's in Japan, so ambulance can obtain the intravenous access and further administration. And ambulance promptly transports the patient to appropriate medical facility. We call it trauma bypass. It means if ambulance declare load and go, so they should transport the patient to tertiary emergency hospital, not the secondary hospital. The fourth, they have to observe the whole bodies, like head palpation, maxillary and jaw palpation, and cervical inspection, palpation, and chest, and abdominal, and the pelvis, and the extremity, and neurological examination. Initial evaluation and the whole body observation should be performed within 2 minutes. So, after good management in pre-hospital care, patients have to transport quickly to emergency department care. From 2002, we started Jtag Protocol. It's a Japan Advanced Trauma Evaluation and Care. So this is a guideline and educational course for evaluation and care quickly at emergency department. In the Jtech Protocol, we performed primary survey. Primary survey is evaluation and care for maintenance and recovery of the physiological function for life support based on ABCD approach. If primary survey is okay, physiological function is stable, we can move to secondary survey. After confirming the program directly connected with life support in primary survey, so after that in the secondary survey, we evaluate anatomical function and care systemically for damage of full body. This is a summary of primary survey in Jtech Protocol. First, we evaluate A. A means airway evaluation and securement cervical protection. Next, B. B means evaluation of breathing and treatment for critical chest injury. After that, so we evaluate and resuscitation of circulation and hemostasis. And after that, we evaluate neurological function. It's mean evaluation of brain herniation. After that, so body temperature management. In primary survey, so this table shows the main site of injury. Site of injury is airway obstruction, flat chest, tension pneumothorax, open pneumothorax, massive hemothorax, and tamponade, hemoperitonum, retroperitoneal bleeding, and brain herniation, and hypothermia. These are very important findings for prevent physiological function. After that, so patients move to the neurosurgical treatment. In the Japan Society of Neurotraumatology, we published a guideline for the management of severe head injury. First edition was published in 2001. After that, in 2007, second edition was published, and third edition was published 2013. And now we edited the fourth edition, maybe next year or 2019 we can publish that. And in 2012 we published a guideline in English version. In the guideline, these contents included. Of course, so it's included the emergency care and initial treatment and imaging, diagnosis, ICU management, surgical indication. And recently, so we added the topics about the sports head injury or higher brain dysfunction or intracranial hypertension syndrome. This is a series for pre-hospital care and emergency department care and neurosurgical treatment in Japan. So actually, so we started 2002 Jtech, and 2003 we started Jtech, and 2000 we published guideline. And between the published guideline, we performed the registration studies. It's called Japan Neurotrauma Data Bank. This is performed intermittently for 2 years. And we saw a result of this study, so we changed the guideline. So, and we tried to stabilization for TBI patient treatment. So we can see the result from Japan Neurotrauma Data Bank. This is the results of multiple trauma, including TBI. Here's a project 1998. It's this project performed before the guideline Jtech, JPTech started. The project 2004 and project 2009, it's after publishing the guideline. As you know, so in Japan, so population age is quickly increasing. So you can see every time, so patient age was significantly older. And this is a transportation time. So unfortunately, it's become long. And this is the initial GCS. You can see the GCS score is increasing. It means so severity of TBI is decreasing. And respiratory rate or PaO2 in the department, emergency department, it's improving. Maybe it's beyond of, it's belong to Jtech or JPTech. This is a result of AIS and trauma coma data bank, TCDB classification, CT classification. And AIS over head and neck significantly decreasing. It means the severity of TBI is decreasing. And the face or abdominal or pelvic injury, severity of these injury is increasing every time, every project. And in TBI, recently in Japan, so diffuse injury is increasing. And this is a result of a functional outcome. Unfortunately, good outcome. It means GOS of GR, good recovery, and MD percent was about between 20 and 30%. So unfortunately, it's not changing after publishing guideline. But we evaluate with TRIS method. We calculate reverse trauma score and probability of survival with this formula. You can see the, you can please see here. So unexpected death is significantly decreased. Before published guideline, it's 42%, but recently it's significantly decreased to about 20%. Maybe this is a result of a published guideline and Jtech and JPTech. So, in Japan, so seamless collaboration in trauma care from pre-hospital care to neurosurgical treatment. So unfortunately, rate of favorable outcome was not changes, and mortality also not changed, but the rate of unexpected death was improved. Thank you for your attention.
Thank you. Any questions from audience? Please.
Immediately. TBI with a high blood pressure and TBI with a high blood glucose. Suppose come emergency, will you start treating it or just will wait for some time?
I'm so sorry. I couldn't understand, but
no,
so
he is asking injury, head injury with hypertension, high blood pressure. How do you manage such a situation in the emergency?
it's a bit difficult because, so of course, you know, so hypertension we should improve. So, but hypertension, so actually in the emergency department we don't treat about hypertension.
Can I answer your question? Traumatic brain injury, if there is high blood pressure, one should know whether there is a raised intracranial pressure or not. For that, probably investigation would be okay. A person with already having high blood pressure gets a head injury, one should try to maintain it in a manageable rate, not permitted to bring it too low, if that answers you. Any other question?
Yeah, at the emergency department, a case of pure head injury, only head injury is there, and the one with polytrauma. Do you have any difference in the referral system or management system? Who becomes the team leader?
Who is the leader in the management? Is there anesthetist, physician, or a neurosurgeon?
Okay. Of course, in the 1919, basically neurosurgeon was leader. But recently, so in Japan, so emergency department is getting bigger, and so in the big hospital, so big hospital has an emergency department. So emergency medicine physician, he's a leader, and a small hospital, so no emergency physician, so neurosurgeon will be leader.
Any question? Yes. Please give me a mic.
Thank you. So the next topic is Assessment and Management of TBI in Emergency Department by Dr. John.
Yeah, good afternoon, everybody. My topic is focused on the. So I arrange overall view and assessment of management TBI and emergency department. Yeah, first thing is my content is like this: classification and assessment and management of medical and surgical preparation. Usually, we know about the GCS score, and it is a very long history. And we are neurosurgeon. Each scoring system is all exposure to our daily life, and we scoring that GCS and mild brain injury in like that point. And if the patient have a symptom, minor or lesser, and dizziness is classified minor brain injury. Usually, early and late symptom is often cognitive and somatic, like headache, dizziness, and sometimes emotional situation. And moderate and severe brain injury is scored like that, and is also different. And more severe case is progress rapidly, and that we classify like that. Their symptom is sometimes talk at night syndrome. It means initially functional trauma and is concussion, and after that recovery, and next is physical compression made the conscious level is decreasing. And it is happen to the epidural hematoma, you know, and next in severe brain injury is also very rapidly change, and is overall patient need to surgical intervention, and is a higher mortality, and usually related with external trauma. But we have to always concern about that, like that. Although the patient lower level of mild injury, but it can be a change of moderate and severe during our evaluation. We are classified TBI two types: in primary injury directly and secondary injury and physiological influence. Yeah, we are usually explain that situation and coup and counter coup, and is the inertial effect, and is happen to bony prominence area like anterior skull base and temporal area and cortex, and maybe happen. Yeah. like that situation is frontal base, and temporal acute imminence is influence, like that. And another injury is diffusion axonal injury, is cell level injury. It means rotational mechanism is shearing force, and the neural fiber tearing, and it makes micro bleeding. It was usually checked by the MRI more commonly, and micro bleeding is where imaging T2 gradient echo, like that, and it's sometimes we degrees diffusion axonal injury according to the happen to location, like the gray white matter and corpus callosum and dorsolateral middle vein. What is the involved in area? Yeah, primary brain injury, the cascade is main factor is the calcium channel. And if the injury calcium pump and affected the cell level of membrane, cell loss is happen, and cell death, and like that. Secondary brain injury is categorized systemic part and intracranial part. We emergency department usually primarily focus on the systemic injury. People, another guy here mentioned about that hypoxia and hypertension also increase the mortality. A lot of papers, they demonstrate increased mortality with the hypoxia and hypertension and pre-hospital and emergency situation also. So we always concerned about that management. Systemic injury and or the hyperventilation is the mechanism. Carbon dioxide is a very potency of the vasodilation, but nowadays some papers announced that only acute period is effective, and chronic phase decrease the cerebral perfusion pressure. Other systemic injuries like that and coagulopathy and under the resuscitation, iatrogenic and make lip fracture and hemothorax, like that. We are neurological main consideration is like situation intracranial hypertension, extraaxial lesion, and cerebral edema. Yeah, usual mechanism fracture and hematoma, epidural, subdural, and intracranial, intraparenchymal hemorrhage, and traumatic vascular injury, like that. Usually, skull fracture delay with a high degree of energy, and location is depressed, and fracture is under the tear of the dura vessel, and fracture of the pterion is a medial meningeal artery, and sinus level is subdural hematoma. When it happens, skull fracture is increased like that, extracranial hematoma, delay is more increased. Like the epidural hematoma, and sometimes is delay with the bone sinus bleeding is massive, and subdural bleeding, is usually delay with the bleeding vein. Intraparenchymal hemorrhage is a small branch of the brain tissue, and like that, and subarachnoid hemorrhage happen to the subarachnoid vessel and disruption. Traumatic vascular lesion can be overlooked initially. It happens in a very rare case, but we don't know about after aggravation of the patient, delayed the check of the cause, like that. Traumatic ICA injury happen lesion, or because the high energy trauma of the neck and the intimal injury, and like that total occlusion delayed the left hemisphere whole brain impact. Another case is traumatic CCF. It is most commonly delayed with the bicycle injury, and like that on the image, and proptosis eye, and bulging cavernous size, and enlarged dorsal vein. Clinical feature is usually related minor symptom is confusion and amnesia. But severe injury is always the mental state, GCS is decreased, and neurological abnormalities showing of the patient. And always the exposure, the clinical symptom can be of progress. Like a confusion, and usually patient complain about that, like coherent train or thought, and short-term memory impairment, and sometimes the loss of consciousness, like that. You know about the Morgan doctrine is a rigid box and cranium, and we are control of the blood, brain tissue, and CSF. One critical point is the overwhelm is very rapidly increase the ICP. You know, causing trial is hypothalamic is ischemia due to low perfusion. It makes sympathetic tone increase and blood pressure increase. But diastolic pressure is not meaningful, and bradycardia is happen because the parasympathetic stimulates the rebound phenomenon, and after that is unstable respiratory pattern. Yeah, we are next step is the neurological assessment and pupil size and reactivity and neurological posture and another sign, and like CSF autoria and linoria and hemotympania, and like the raccoon sign is mean on basal skull fracture, you know. Yeah, we assessment consciousness is divided into 5 steps, and like that. And drowsy is obey between stuporous, and semi-coma and stuporous is spontaneous movement, and semi-coma and coma is a pain response. We also always check the pupillary reflex is happen to herniation, and it will be affected ocular nerve, and like that. But the patient have medical compromise and metabolic coma, bilateral diencephalic damage, pinpoint pupil, but it has light reflex. Another case is pontine damage. It was not reactive, and it is a brain death, and full coma state is a bilateral unreactive delayed pupil. Like that position is related with the pupil size, and midbrain, hippus, and tegmentum is a more large size hippus, and like that. Yeah, we also checked the fundus curve and acute period, the retinal hemorrhage congestion happened below like that, but it progressed chronically, and papilledema showed the upper image. It caused by the optic nerve sheath compression and venous circulating compression. We also checked the brain stem reflex, oculocephalic reflex, oculovestibular reflex. Abnormal sign is below 2 image, and not follow forwarding, and the oculocephalic reflex is not reflects the stimuli with the water. Usually we always check the score, but sometimes some group, they did not routine schedule, but X-ray is very important because it is some source of the radial opaque foreign body and penetrating injury, and more delicate skull fracture detect, and so we have a window level adjust, and we can check the like that situation. But usually acute period of the trauma TBI and CT is definitely benefit, because it's very fast and widely available, and sensitivity is good, and But sometimes it could not explain about that patient's neurological state. At that time, MRI is a part of that. Our hospital is like the situation, CT indication. We follow immediately announce the article. MRI is very sensitive, or primary or secondary injury and more than CT. But it's a limitation like the patient have a metallic foreign body and fracture, not sensitive, and or hyperacute blood like that image is not sensitive to MRI more than accuracy, high accuracy CT. In our hospital, focus on the management in the mild and moderate severe group, and mild head injury is regulation, but moderate and severe head injury control or about the from the intervention. Yeah. Usually mild head injury is potentially have a risky progressive second injury, so we are always having a instruction like that, warning sign to the patient, and after the patient discharge, we recommend it like that instruction, and also explain that the patient to when it could possible the activity like that. So we have admission criteria and discharge criteria like that. Any abnormal happen to the patient, we are naturally discharged to the patient, but he has or she have like that some abnormal condition. We are explain about the admission just one day, and like that. And more severe head injury, and we manage our focus on intervention, and we are initially, airway control into early intubation rapidly, and we don't use lidocaine and not beneficial. And hemodynamic assessment, we are always cerebral perfusion pressure using inotropic agent, and and normal saline, isotonic saline is more benefit any other fluid. Yeah, we also sedative analgesia, neuromuscular blockade used, but we have to check the neurological condition serially. We don't use acute period on barbiturate and neuromuscular blockade. Although it is agitation and irritability affected the patient ICP, we are more focused on neurological checkup. It is acute period also. Some guidelines have announced that prophylactics is anticonvulsant is a benefit. So we usually do first period 7 days. Use oral IV or oral anticonvulsant use. Refractory. When it has a refractory condition. Usually do right compressive craniectomy, but sometimes it's not benefit of surgery. We choose the barbiturate coma, but also it changed the ICP increase and not response, and we have to choice consideration about the surgical procedure. Let's take a look some case series, summary of case. 67-year-old man slipped down step and pop, head injury. GCS initially 10, like that. He had irritability. He had a hematoma on his right temporal region, It announced the people right there. The high risk patient, we do check the CD. We graded right there. Minor, moderate. He has a moderate group. Primary, secondary differences is main objectives is primary. After primary injury, we are focused on the prevention of the second injury. Rigid box in brain, and we are all control with the blood flow by CSF, but if we need to do decompressive surgery, it's controlled with the brain teeth. Right there. It's just autoregulation, and after traumatic brain injury, it happened to the disturbance, and mean arterial pressure is directly affected the cerebral blood flow, likely linearly. So the optimization of the blood pressure is a very critical point. He is a condition of check the CT because like the criteria involved in most Icp sign or mass effect sign like that. Initial his CT we check like that, right side subdural hematoma, but it was not mass effect. CT is a small scanty amount of those hematoma. But on return 1 hour later, ER, trauma bay, his neurological state to more aggravation. And what you do next step? Recheck CT, more increased size hematoma. It was changed situation. And primary, we have to intubation and pressing check and circulation and control of the mean arterial pressure and oxygenation also. And recheck the neurological state, pupil light reflex, pupil size, and motor function, and any other posture, and the body temperature, normal temperature. After that, we again EKG and monitoring and any other trauma injury, head and toe, and we contact an surgical team like that and turn over. Thank you for your attention.
Thank you very much for a nice, elaborate presentation of head injury. But one thing I like to ask you, whether there is any limitation of waiting observation in emergency department for traumatic brain injury. If so, how many hours or how many days you wait in the emergency for traumatic brain injury?
See, he is asking, when you admit a patient in emergency ward, how long you make them wait? When do you transfer to the different ward?
Nowadays the Korean society is some change. It means some group have a traumatic center, but another group is primary core neurosurgical team. Our hospital, it does not exist the trauma team, only our faculty of the neurosurgeon. So like the situation, the primary core always connected to the neurosurgical resident or staff. But another traumatic center, they are core initially ER medicine and neurologist and neurosurgeon, they are come together one place, and I know it. But usually, in that point, the time it is saving, like a situation, very concerned. But yeah, in our hospital, usually do rapidly more. So I think it's not, but it's not comparing, but it's experience, just the experience. I think it's not different. Yeah.
Okay. Any question from audience, please? Yeah.
Do you give anti-epileptic drug in case of a traumatic brain injury prophylactically, and which one you prefer? Which anti-epileptic drug you prefer?
Yeah, we are first choice is valproic acid IV, and it's not happen to a seizure event, and we use the diazepam, but it was not affected of the seizure-like movement. We use the midazolam continuously, and after the change DPH.
Anyone? Yes,
there are two ways in which the brain can swell up. One is the brain traumatic edema, and the other is, you said, vasoparalysis or venous congestion. So in either case, what is your treatment policy? If you could diagnose them on CT scan.
You mean the
traumatic brain edema?
Traumatic brain edema.
Vasoparalysis, venous congestion.
And vasoparalysis. How do you treat these two? You asking this, sir?
You mean the first check of the brain CT? The CT is showing the brain edema. How long time takes the next step? You mean? I just don't understand. We are usually routine check CT about 6 hours, but like EDH and high energy trauma, time is more very rapidly, like 2 or 3 hours. But it's a simple trauma. The patient general state good. We check sometimes 12 hours.
Any more?
See, it's below 50 is raised to 60. Any more questions from the audience? Hey. Okay, I have one. Thank you very much. Thank you very much. Yes, any more questions? Dr. Tripathi.
Actually, I was asking the same question Professor Sahu has asked. In ER department, you got a head injury, which is mild head injury, with a seizure attack, single seizure attack. Now, what is your protocol? So, do you start anticonvulsant? I'm not talking about diazepam or midazolam. Whether you start anticonvulsant or not. If you start, how long you will continue for that?
Yeah, you mean the image is not large amount of hemorrhage and large amount of brain tissue injury, but the mild head injury have a seizure event. We choose like that protocol within 1 week. Use valproic acid, or nowadays we more use the Keppra. Keppra is a new type of anticonvulsant, and after that, just follow no event, we stop it. Yeah.
Okay. Thank you.
Thank you very much. I think we have more time now. So I just want to make an observation. For they are visiting our visiting doctors, that pre-hospital care, we have learned to give more importance to the golden hour. Be it head injury, whatever it is. Any pre-hospital care, first hour treatment would determine what will happen next. Now, in case of brain injury, in case of head injury, we have in Indian literature, is the platinum minutes. That stresses the anoxia and the damage which it would cause, and that damage probably would reflect the outcome of the patient. So we call it platinum minutes. I think all these facts have been very well presented by our speakers, particularly Dr. Ellie and two gentlemen. And I thank all of you for this patient hearing and thank my co-chairpersons.
Thank you, sir. May I request you all to be there on the dais, please? I would request our speaker, Dr. Eishi Shuero and Dr. Hong, to be on dais, please. I would request Professor Dr. B.S. Das to please present the memento to Dr. Eishi Shuero. I would request Professor Dr. S.C. Mohanty to present the memento to Dr. Hong. Thank you, sir. I would request Dr. Hong to present the memento to Professor Dr. B.S. Das.
You have to present this to me.
I would request Dr. Eishi Shuero to present the memento to Dr. A.K. Srivastava. I would again request you, sir, to present the memento to Dr. A.C. Mohanty. Thank you so much. Thank you to the chairpersons and the speakers. Now we are entering to our third technical session. To chair the session, I would like to invite Professor Dr. A.K. Srivastava. Dr. A.K. Srivastava is serving as a Director Professor, Neurosurgery Department at G.P. Pant Hospital, New Delhi. Sir, may I have you on dais, please? I would request Professor Dr. Brigadier P.K. Sahu to be on dais to chair the session. Professor Dr. Brigadier P.K. Sahu has passed his MBBS from SAB Medical College in the year 1975. He has done his MS from AFMC Pune in the year 1985 and MCH from All India Institute of Medical Sciences. Currently, he is serving as a Chief Consultant Neurosurgery Department at Apollo Hospitals, Bhubaneswar. Thank you, sir. Now I would request Professor Dr. S. Raul to be on dais, please. Professor Dr. S. Raul, serving as a Senior Neurosurgeon at Jamshedpur Multispeciality Hospital. Requesting our chairpersons to conduct the third technical session.
Very good afternoon to everybody. In this session, we have got two interesting topics. The first topic is by Dr. Icp Suehiro. He is from Japan and he will be speaking to us in IC monitoring in traumatic brain injuries. I request Professor Icp Suehiro to kindly come and speak on traumatic brain injury. I know that he had a very difficult time to come till last day. He could not get his visa, but we arranged so that he could get his visa and he has come here. Please.
Thank you very much. So before my talk, so I have to talk, I have to speak, I have to show my appreciation to organization of this meeting and of course Peter, Larry, so thank you very much. So next my talk is about Icp monitoring in TBI, especially in Japan, so current use. So, you know, so in TBI patient treatment, especially in intensive care, so ICP monitoring is required. However, you know, so a benefit effect of ICP monitoring has not been shown in much clinical trials. Yeah, and there are currently arguments for and against use of this technique. So we evaluated the current use of ICP monitoring using information from the Japan Neurotrauma Data Bank. In this talk, content is ICP CPP management from guideline for the management of severe head injury in Japan, and clinical practice for severe TBI from the Japan Neurotrauma Data Bank. I already talked last session, so we published guideline of management of severe TBI patients. In this guidelines, we show the indication for ICP monitoring. Number one is a Glasgow Coma Scale score of 8 or less, and number two is hypertension, and number three is abnormal CT finding, like brain hernia finding. It's been midline shift or compressed basal assistance. And additional indication is like barbiturate therapy under barbiturate or hypothermia treatment. It's under the sedation, so we cannot find the finding of a neurological state. So at that time, we should use ICP monitoring. And the sort of ICP, it's a value of 15 to 25 mmHg desirable to start aggressive treatment. You know, management of ICP, we have to perform the treatment. Like these slides, stepwise treatment. First, less invasive treatment, so just sedation, ventilation, or neuromuscular paralysis, and after that, head up or ventricular drainage, monitor, hypothermia, surgical decompression, barbiturate coma. But our purpose in treatment in severe TBI is not management of ICP. It's oxygenation of brain tissue. For oxygenation of brain tissue, we have to maintain CBF. For that, we have to maintain the cerebral perfusion pressure. In our guideline, treatment threshold of CPP is 50 to 70 mmHg. However, the proper value are different, depends on individual. Actually, so this target of CPP is made based on these data, these physiological or outcome data. However, the proper value are different. Why? Why is the optimal CP value different? Depends on each cases. if there is an impairment of pressure autoregulatory capacity, it's, so if autoregulation is no function, so, vascular is dilated, so increasing of CPP, it means increasing of blood pressure induced just intracranial hypertension. And as a result, disturb oxygenation on brain tissue. By such situation, the optimal CPP is changing. So only management of CPP is not able to give us oxygenation of brain tissue. And if autoregulation is impaired, we need more monitor, like oxygen saturation at the valve of the jugular vein or partial oxygen pressure in the brain tissue. This is in our hospital case. Patient is severe TBI patient in our hospital between 1995 and 2009. Number of patients was 166 cases. Actually, so after published Japanese guideline, it's 2001. Before this, we didn't manage ICP so aggressively, but after published guidelines, so we aggressively ICP management. This is the bedside monitor of in our hospital. So actually, so we do temperature management. Or this monitor shows ECG, blood pressure, and ICP, CPP, and for evaluate auto-regulation, we are showing here PRX. It's a different story about PRX, but PRX showing the PRX can evaluate the auto-regulation. This is the result. Before aggressive management ICP, so ICP monitoring just performed 24%. But after that, so the second time, we performed ICP monitoring rate of 84%. And in the first time, we didn't decompressive craniotomy, but recently we aggressively perform decompressive craniotomy. And the rate of perform hypothermia also different. This is outcome. Under the strict and aggressive management of ICP, we could decrease significantly mortality. However, unfortunately, we couldn't actually no change about the functional outcome. Actually, this is recently we can see the many paper about ICP management, but this is real. So almost paper can show the decreased mortality, but no functional outcome. So multi monitoring could evaluate cerebral oxygenation and pressure autoregulatory capacity, which cannot be caught with only ICP CPP monitoring. This knowledge is very important to treatment for severe TBI patients. And next, I'm talking about clinical practice in Japan from a Japan Neurotrauma Data Bank. This is inclusion criteria of Japan Neurotrauma Data Bank. So basically, only severe traumatic brain injury. It's a GCS score of 8 or less 8. is include this study. In this study, so 22 centers participate. All centers, in all centers, aggressive TBI treatment. Data sheet is, contents of data sheet is like this. So patient background and the situation of neurotrauma, information from previous doctor, and extensive alcohol, neurological finding, therapy and outcome, and final diagnosis. In this study, so I divided into two groups. ICP positive group was patients treated with ICP monitoring. And ICP negative group was patients treated without ICP monitoring. We evaluated about the age and the GCS at the admission, pupillary findings, ISS, CT findings, and maximum ICP during treatment, therapeutic treatment, and length of hospital stay and GOS at discharge. This is a real, but you know, in United States, maybe rate of ICP monitoring in the severe TBI patient is maybe 70 or 80%, especially after publishing the guidelines in United States. ICP monitoring patients is significantly increasing, but unfortunately in Japan, so now just 28% was performed ICP monitoring, even after publishing guideline. And we evaluate age, so in the ICP positive group, patient was significantly younger. However, GCS score was not changed, no difference, so it means the severity of TBI was not different. Pupil abnormality and ISS, no difference between the two groups. This is a TBI types on TCDB-CT classification. You know, so basically in ICP positive group, diffuse injury 3 and 4, and evacuate mass lesion. ICP plus group patient was increased, significantly increased. I think it means diffuse injury 3 and 4. It's you know, very diffuse swelling. We can see the brain herniation findings on CT, so maybe everyone use ICP monitoring. And evacuate mass lesion, it's you know, so on operation, so maybe it's easy to insert ICP monitoring during the operation. This is a result about cerebral hernia finding on CT. You can see the significantly increased patients in ICP positive with brain cerebral hernia findings. You know, so the method of ICP monitoring is so various methods. There's various methods. For example, subdural space or epidural space, brain tissue, and ventricular. In United States, so many ventricular drainage with ICP monitoring is recommended, but in Japan, so brain tissue ICP monitoring is most big, most large. And this is a result of outcome according to maximum ICP. So you can see that if we can manage under 20 millimercurator of maximum ICP, favorite outcome patient was significantly increased. And if so, maximum ICP was over 40 millimercurator, mortality was significantly increased. This is a ROC with ICP and favorite outcome. We can decide the cutoff value of 22.5 millimercurator. It means if we can manage the ICP under 22, patient will be good outcome. This is a treatment. As you know, you can see the ICP positive group. Every therapy, so significantly increased. It means with ICP positive patients was performed very aggressive treatment. This is about the temperature management. So if we perform the hypothermia or induced normothermia, we often use ICP monitoring, but no temperature management, so we didn't use ICP monitoring. This is a clinical outcome. Even if we use ICP monitor or not, favorite outcome was not changed. But if we use ICP monitoring, so mortality could decrease. This result is same as our hospital result outcome. Conclusion. The rate of ICP monitoring was just 28% in this study, actually, in Japan. The target of ICP monitoring was a case with suspected elevated ICP on CT. The maximum ICP has reflected clinical outcome. ICP sensors were most commonly placed in brain tissue in this study, and all treatments for elevated ICP were performed aggressively in the ICP positive group. And finally, the result indicated a significant reduction in mortality in the ICP positive group, but no improvement of the favorite outcome rate. So this is a target in future for us in the TBI treatment. Thank you very much.
Can you tell us which type of monitor you use in your institution? Secondly, when you have told regarding the IC monitoring, you have not mentioned regarding the CT scan finding, only on whether you do on only Glasgow coma scale scoring, you do IC monitoring, and whether you do all conjugate cases or you do only selected cases. Which IC monitor you use?
I mean, so you mean in Japan, so most doctor use ICP monitoring based on CT findings and no GCS scores. Right.
You said that brain tissue monitoring, that's you are putting the electrode in the brain tissue. Is for the once you are treating conservatively or once you are opening and operating at that time? So is the because we are doing intracavitative pressure monitoring after evacuation of the hematoma for the further prognostic index. So is the same brain tissue monitoring and intracavitative monitoring?
You mean brain tissue monitoring? You mean oxygen, PBTO2? Actually, in our hospital, I am using that, but it's a limited area of measurement. So actually now, I think I cannot use fully. I mean enough. So because the area of very limited.
If we translocate this to our scenario, I understand big institutions are using it, but is it feasible? After having corrected when you anticipate ICP, then probably first thing we do is correct the electrolytes, correct the oxygenation and ABG, then we think about it. But how difficult it would be, whatever the complications it is like he's insisting on an intracranial. That is okay when you are operating to put in a sensor. But if we give it only for ICP, will we be likely to get into some other problems like infection or the expenses, etc.? How often it is being practiced in our country? Can somebody reflect it? So, I think you have been a master of
that. Before I answer him, I would like to ask him whether you are using, when you say that you're putting your sensor into the brain tissue, so are you doing it conservatively?
Okay, I'm using the probo brain tissue, but the last question, I'm sorry.
Whether you showed in your slide you are using in severely brain injury patients who have GCS less than 8. So is it mandatory for all GCS 8 and below to undergo a ICP monitor?
Yes.
And which device you use to measure the ICP?
First, we should use measure ICP.
Which device? What machine you use to measure the...
machine or ventricular drainage, you mean?
No. Which
brain tissue
which instrument you use to measure the ICP?
For me, so it's brain tissue, but also just it's easy to insert for us.
Okay. We are using the Codman instrument for measuring, and we usually do the placement into the parenchymal tissue as they are also doing.
Yeah.
And that it is hardly 1 mm of thickness of that sensor, and which we can enter with a very small twist drill. And the infection rates, though in the initial phase we had a little bit of infections in the early stage, but it has mostly been taken care of, and that has not given us any problems in the long run. And even we have results which we will publish shortly. The study is still going on, and we have got very good results as far as mortality is concerned, which also he has shown in his results. So we have got improved as far as mortality is concerned.
You feel your residents could do it in emergency?
Yes, we are regularly doing this, and we've got a good series. Maybe by the next year we will be publishing it.
I think it could be one of the protocols it hasn't come any of the written protocols, at least in our country, so it should be, I think, introduced. Because it's not that difficult, even it's small.
No, it is not at all difficult. Our residents, when they receive the patients and get them to the ICU, we have adjacent OT, so we always try to take it to the OT complex and put the ICP sensor in. So that saves the infection part. If you do bedside, definitely chances of infection is there. So otherwise we have not had any major complication with that.
All your ventilators are capable, compatible?
Sorry, I didn't get you.
All your ventilators are compatible with any type of intracranial ICP monitors?
Yes.
All of
it is all compatible.
As a matter of fact, there are certain modifications which can be done because the sensor itself costs around 40 to 45,000. So therefore, in each case, you may not be able to do a sensor when a person is extremely poor, cannot afford, so you cannot do it. In such situation, there are certain modifications which is being planned so that you use the monitor in ICU and devise certain devices which is very less costly and it is not 40,000, 45,000 that can be used. And results also can be shown that is quite comparable. Results are quite comparable.
My question.
Yes, sir, you want to speak something?
I have a question. Yeah, actually, do you measure the ICP in all cases by intraparenchymal method?
No, suppose, as he has said, suppose you are operating a case, you keep intracavitary. If you are not operating, you put intraparenchymal. If you are done the EVD for some pause, you put intraventricular. So
what my question is this: in TBI cases,
yes,
if you have intraventricular, this option is always there. If there is a pressure high, then you drain the CSF. But if you put intraparenchymal in all cases, the ultimate that if it is reaches the refractive stage, then you go for decompressive cranectomy.
And what you are saying, in a traumatic brain injury, the evolving process, and you may find the ventricle totally chinged.
Yeah, many
so
cases.
Massive, you do ICU monitoring, when, as he said, it is less than 8 score, or you are operating, you find brain bulging out. So putting in a ventricle may be difficult, so therefore you put in a cavitary or you put in the parenchyma, leave in the parenchyma and then you do it. In contrast, suppose there is a hemorrhage and there is a large, because of blockage of third ventricle, fourth ventricle, there is dilation of ventricle, probably if you can subpercutaneously you can put the catheter and monitor it. So therefore it is not always technically possible, or you should not try also, because it has been observed whether it is intraparenchymal, intraventricular or cavitary, the results almost nearly equal, and it will definitely guide. Suppose the ICP is more than 40, 50, whatever you do, that person may not, even if you do decompressive craniotomy, the results may not be that good in such situations. When you are monitoring, you find the ICP is less than 20, definitely results are better in such situations.
And we have one reason, so because we are using a Camino ICP monitoring, so it's only the probe to brain tissue, parenchymal tissue, no subdural or subepidural space. We cannot insert that.
So for the Cordman monitor, we can put it inside the parenchyma, but for the intraventricular catheter, what Tripathi sir was telling, it has to maintain a water column to show inside in the ICP monitor or in the what we see in the JVP line. So you have to put it inside the ventricle, and we have to continuously monitor that, and that reduce the cost from 40,000 to around 440 rupees. And this practice is almost, I have talked to my friends from Japan, from Bangladesh, Sri Lanka. This part of the world, they use this type of monitoring, which is for which the cost is very low, sir. And it also give good results, sir.
Okay, thank you.
Thank you.
Yeah, next we have Hanju Jian talking about the low barbiturated trauma therapy by using bispectral index monitoring.
Thank you, Chairman. Second, my topic is our experience in control of the ICP using by barbiturated induce coma, and it also published the article. Traumatic brain injury initially we separate like this first-tier intervention and second-tier intervention. Is initially had the elevation is a physical component and pneumonia and pain control, ABC, and short-term hyperventilation, and osmotic agent, hypertonic, and or monitor. Sometimes we use the EVD. But second-tier intervention is representative with the decompressive craniectomy or barbiturated coma. Some controversy exists is announced hyperthermia therapy. Our indication is proper management of the first-tier intervention. It has not failed. It has failed. It changed the surgically or medically barbiturated coma, and using use the barbiturated coma, we first option always close to the decompressive craniectomy firstly. For sometimes it's not surgical option is not proper. Where after surgery, also Icp indication is very highly increased. We choose the barbiturated coma. Barbiturated induced coma is a mechanism like this. Two drug component is thiopental and phenobarbital. They are very rapid action, and the action is dose dependent. And interestingly, they are reversible brain function, but pre-radical scavenger is more benefit thiopental therapy. It is a very short-term effect, and after that they are lasting half hour like that long period because they are storage the adipose tissue like a fat saturation. In this coma is making metabolic working is decreased on the brain cell, and also blood flow is decreasing. It is your main effect, and making a metabolism is shut down. And it also reducing the TCA cycle, and it has made low consuming of glucose, and also it is GABA activate channel is regulate is that drug. EEG is signal is changing is wave is burst silently. We are usually check people BIS, EEG. The phenomenon is a burst suppression check. Burst suppression like this, the signal on EEG, and the left side is not barbiturated coma state, but we have action to the increase ICP, and using by barbiturated coma, the burst suppression like that. No EEG activities pulse. Shortly after that is 3 or 5 bursting of EEG activities checking by per minute. And we the goal is in this coma is like that burst suppression usually do previous announced article, and ICP is control below 20 mercury. But cortical electrical silence checking the whole EEG gram, and also SS if and BA if is just we have a stimuli check. Using barbiturate-induced coma, we selected the thiopental. But another group is they are more preference and phenobarbital. They also published more than benefit, but our experience, we are more benefit thiopental rather than phenobarbital. We believe it. So we initial group is a high dose, and second group is a low dose, like that. The below the half, but loading dose is the same. Main problem is barbiturate-induced coma is to consideration and cardiovascular compromise, hypertension, and EKG change, prolonged QT, because it directly impacts cardiomuscular cell, and action potential is decreased, and potassium channel is disturbance, and prolonged QT is happen. And another problem is electrolyte imbalance, like that hyponatremia, hypokalemia, because of all sodium potassium channel disruption. And other trouble factor is very delicate problem, because sometimes is related with situational mortality, like infection, pneumonia, and catheter-related infection, and UTI, and also the progression, DIC, septic shock, because it also shut down our immunity system, like immune-compromised patient. We are immunologist there, and macrophage, and cytokine, and like that. It's not well function of the defensive of the out environment, so more vulnerable condition. And direct CNS depressant is hypothalamic dysfunction, and that patient also check, and hormonal imbalance will be shown. This is a BIS monitor, and the left side shape is a cartridge, and saturation rate is mean during 1 minute, how percent of saturation of the EEG ratio, that means saturation ratio. And it is interpreted the BIS scale, and continuous EEG monitor, and also physiotherapy EMG monitoring is possible. But high dose coma therapy is targeted in below BIS score is below 20, it means burst suppression, but we are targeted a deep high hypnotic state, it means cortical suppression. We are target usually are more than 20 and below than 40. We also combine the amplification monitoring like that. We are ICU daily managing A-line monitoring and CVP. Sometimes we catheter insertion in Swan-Ganz catheter, check the cardiac output index and stroke volume, PCWP. We are control of volume. And neurophysiologically BIS monitor using, and also ISP monitor used to check the CPP. We are guideline is normotensive. We don't use the hypo temperature therapy, and also check the tissue oxygen, and sometimes check barbiturate serum level. Therapeutic endpoint is within 2 or a week, and sometimes we only winning after 3 or 6 days. And successful condition we define like that. ISP below 20 mercury at least 48 hours, and midline shifting is more resolved, and the general swelling is also resolved, and the serially, and the ICP is stably sustained. And pale condition like that is a brain death, uncontrolled ICP, and intolerable side effects, and cardiopulmonary insufficiency and hypertension and pulmonary dysfunction or sepsis. Either the main factor is affect the payload therapy. Barbiturate BIS monitoring is a benefit like that because that medication is controllable. Titration is some typical because we do not use EEG. The patient, how does he sustain his condition? Underdosing of payload control ICP, overdosing control of the side effect. So BIS monitoring is non-invasive. It's just very less laboring because we use when you use the high dose chemotherapy with the barbiturate BIS monitoring, we use the EEG, continuous EEG monitor. But if we choose the continuous EEG monitor, we use the special neurologist or special nurse or marking man. Yeah, it's very laboring. Each paper is announced the barbiturate coma benefit. Severe ICP patient, 10-year experience is suggest that controllable ICP clinical outcome have shown benefit. Other studies like Meta, and they data together announced that about the high dose and low dose and no barbiturate. Barbiturate also have a clinical benefit, but high dose and between two groups with the high dose and low dose, no difference of exists. But high dose is more increased stay of the hospital and more complication, electoral imbalance, infection. BIS application is announced that anesthesiology department, they are using a multiple trauma patient management to BIS score within a sedative agent. It is very good correlation of the conscious level. I also, it is also another group, and barbiturate severe brain injury patient. They using a barbiturate, only barbiturate to use. They check the burst after burst suppression, the suppression ratio, and the EEG, very close correlation. They show their outcome. I also published the correlation low dose barbiturate coma with BIS scale and without BIS monitor, just using high dose coma. But low dose coma therapy is definitely benefit to our design. Like that situation, monitor like that, surgical intervention we are actively perform. To group is no demographic difference, but low dose barbiturate coma is more longer stay in sustain of the with the medical complication and more long period and later side effect. You can show that. Also. A lot of articles they announced that serum potassium level is very unbalanced of high dose barbiturate coma, but we use protocol and low dose state is very meaningfully improves the potassium control. And so, like the situation, traumatic accident, 33 male patient. Initially semi-comatose mentality. Where in this case we urgently perform a decompressive craniectomy because we more focus on the patient's mentality and image is general swelling, actively decompression. But on left side, the exist epidural hematoma is rapidly increase. It's just the post-CT like that. No, sorry. After 1 hour later, like that, is a very massively increase with a more aggressive change his mental state. And we are BIS core monitor after also decompressive with the EDH below image, and we use the BIS core and low dose barbiturated chroma. Yeah, well controlled. 3 months GOS outcome is a good. Yeah, it's my summary. And barbiturated chroma is a good option of the ICP control. But low dose with the BIS scale is more benefit with lowering the complication. Thank you for your attention.
By now you have collected information about the benefits of this vis-a-vis the toxicity of the barbiturate, particularly in young infants and elderly with the lung complications.
You mean, yeah, they are all, most group is younger. You mean,
present by now you have continuous studies. So do you have information to add to that? This is a good. Your results are good. You are happy. But do we have some additional information regarding its benefits vis-a-vis the complication of barbiturate, particularly in young infants and the elderly people with COPD or other lung complications?
Yeah, you mean the originally that patient have a pulmonary problem like a COPD and another asthma. Yeah, sorry, I did not separate that delicate data. Yeah, you are good mention about it. Thank you.
Okay. Any question? Yeah.
In a patient of traumatic brain injury, for GCS is 8, you find theta, delta, and some electrical discharges. But when you give barbiturate, what happens to that? You give this gross suppression pattern and electrical silence. That's your criteria for what?
Yeah, severe TBI patient, we choose the barbiturate chroma. It was burst suppression, you mean? But he had sometimes showing a delta wave and electrical purge. At that time, we used the acute period it affected the ICP increation. We used the loading one more time, like barbiturate, pure tiopental barbiturate. Usually calculate the loading dose one more time.
Any other question? Okay, so if you have no questions, now we. Yes, sir.
Now, ICP monitoring comes up in the most of the neurotrauma meetings we have in this country. To do or not to do, benefits and no benefits. So here is in this region, pardon me by taking this liberty, how many of us are neurosurgeons? Can you raise our left hand? Come on, come up. How many of us are neurosurgeons? You are not doing it. So many. Fine. How many of us do ICP monitoring regularly? Can you raise your right hand? Yeah. So, sir, I would not include you. Sorry. There are only 3 hands. No, 5 hands. And out of these 5 hands, 3 are from one center. And I do not know whether they do it regularly or whenever a patient who can afford 40,000 rupees is available. Is that correct? Yes, yeah. So, those who are not using, is there any other method of assessing? We have clinical, we have radiological, we have a non-traumatic method of ultrasound test, and certainly the most important is clinical. Now that a treatment is available for this, which is the decompressive craniotomy, can we assess from all this sort of intracranial monitoring? I would ask Dr. Kelly really to answer this question. Can we manage with the associated non-traumatic procedures to assess the raised intracranial pressure? And presently the treatment of choice is decompressive craniotomy. Can we do that? Can we save some patients?
Well, thank you. I was planning to say something about this later, because I in fact will be presenting the paper on decompressive craniectomy a little bit later. But perhaps I can just refer, firstly, I'll discuss the results of the 2 trials on decompressive craniectomy then, but just perhaps point out that both of them show that they could control intracranial pressure. But the problem is that the outcomes at 6 months were not improved in either of the trials. And so there is a sort of a broader question about treatment of head injury, and that is how can you choose, or how can you prognosticate when you have to make decisions at the crucial early stage, whether you ICP monitor, whether you do a decompressive craniectomy or not. How can you make that decision? And at the moment I say that we do not have the tools to do that. But we might, but I'd also point out refer to the Chestnut papers on ICP monitoring, where Andy Chestnut, who's been a great proponent of ICP monitoring, did the controlled trial of monitoring and not monitoring, and found that the outcome was not improved by ICP monitoring. It has been pointed out that the non-monitored patients were managed very thoroughly in intensive care with good physiological control, and subsequent working party looking at these papers with Dr. Mars, Dr. Chestnut and others recommended that ICP monitoring be routine in severe head injury, that is to say GCS less than 9, and with other criteria too, but that's generally the recommendation, because it helps to guide the duration of management. It has some benefits, but the question of long-term outcomes still remains a real difficult one, and that raises the question of the ethics of treatment. The question of whether there are other modalities that you can use, and I plan to refer to a paper that I just read before coming from Dr. Marapatra concerning brain tissue monitoring in decompressive craniectomy, and that people with certain indices on the brain dialysis, that's to say, that indicate a poor prognosis. So it may be, and we've talked about targeted therapy for the last 20 years with the various tools that are available, tissue oxygen, brain dialysis, tissue dialysis and so on. But it may yet be that there are markers of injury detectable early that will guide prognosis more accurately, and so the question that you raised might be possible to answer But I think at the moment we're still dealing with a situation where we have very limited tools to deal with severe head injury, and that the main target that we aim at is ICP, but it's not a complete target, it's only one aspect of the brain injury.
So, nobody denies the fact. Sir, please, sir. No, that's all. Okay, sir. The only constraint is most of our centers do not have access to ICP monitoring. Most of our centers. And some of our centers have access to ICP monitoring. Those who have access to the ICP monitoring, they are doing a scientific job. Absolutely no two opinions about it. Now, when we do not have, we must utilize our clinical sense, radiological informations to attend it. Certainly, microdialysis and many other things can be done during ICP tissue monitoring. And as doctor, he said, the ventricular drainage can be done if the ventricular pressure is maintained. But only when we don't have it, we do not have to say that since we do not have it, we cannot adequately treat the patients with raised intracranial pressure. Thank you. You are.
Sir, I'd like to comment on this. Sir, Dr. Sahu this side, sir. If you do not have a proper IC monitor, if you do not have the proper sensor, still you can monitor the ICP. And the monitor which is using for pulse seeing the oxygen saturation, that can be used for monitoring ICP. They have to have little additional information on that, so you can do the ICP monitoring, that where you see the heart rate, the pulse, the oxygen saturation, the respiration rate, that itself can be done. Second aspect, whether you require always a sensor or not. As a matter of fact, we have almost done 60-70 cases, and it is very preliminary to say at least we will do 100-150 cases to say that with this modified method, and which, as he has said, spending only 1,000 rupees, if your monitor has got the facility to record, where the arterial monitoring is there, you can record the IC monitor, this can be done, and has been found to be very effective, not only while you are planning for any surgery, even after decompensated craniotomy, you would like to know whether the ICP is more or not. And that is a very clear guideline for managing such patients. Now, of course, what he has said is the bispectral index and the therapy by all these drugs. We have not tried that because when somebody is very critically ill, when already there is vascular instability, respiratory instability, we will not like to give the drugs. Even if you are monitoring ICP, the IC becomes 40, 50 or 60. Because you like to lose a patient when you are doing this. So we are not doing it. But even after decompensated craniectomy, the IC monitoring in a modified method can be done with low cost, which helps in management of such cases.
Sir, one thing I want to say, can we devise something non-invasive monitoring of the ICP? We should not put anything, and we can measure it from outside. Suppose the intraocular pressure. The intracranial pressure usually transmitted to the eyes. So, can we get some knowledge about the intracranial pressure from the intraocular pressure? And we have to study that. And from the transcranial Doppler, we have to correlate that how the ICP changes reflected in the transcranial Doppler also. So, if you can devise some correlation between the intraocular pressure and intracranial pressure in case of a traumatic brain injury, so we do not have to put an invasive monitor. We can record it from outside. So, anybody has any idea about that?
Yes, there are various attempts to measure ICP or get an index of it from oral pressure, from ocular pressure, and as you say, from the transcranial Doppler. And the people in Cambridge, and we tried their program for a while, Ian Piper from Glasgow came and helped us to set this up, and looking at trying to measure brain compliance by using continuous transcranial Doppler.
It can be done. It's technically difficult and it requires a dedicated team to do it. But I suppose, and I think it still remains, these things remain in research departments. But I just come back to the point that Dr. Sahu was making, that first of all, remember that the catheter, intraventricular catheter, is still the gold standard. It's still the recommended gold standard in the Brain Foundation guidelines for ICP monitoring. So when it can be done, it's the cheapest way of doing it. It's also the best because you can by draining CSF, you can get some control of ICP. But it's not always possible. But I also point out that the paper of Chestnut and others too have also indicated that you can get very good results from managing people with severe head injury without ICP monitoring, so long as you use the other elements that the guidelines point out so clearly, of blood pressure, oxygen, electrolytes and fluids and so on. And so it's possible to manage people well without ICP monitoring, but ICP monitoring is probably preferable for other, because it gives you a better an overall guidance if you can do it. But a catheter is a good way of doing it if the ventricle can be got into.
So with this, we close this session, and after lunch, we'll all go for lunch. Thereafter, the next academic session, scientific session will start. Thank you very much for attending.
Thank you everyone. Before that, sir, may I request you to be on dais, please? I would request Dr. A.K. Srivastava to present the mementos to Dr. Brigadier P.K. Sahu, sir, and Dr. S. Raul. Thank you, sir. Sir, I would request you to present the memento to Dr. S. Raul. Thank you, sir. Thank you, sir. Now moving on for our lunch break. Ladies and gentlemen, this is the time for meal. We will be resuming here at 2 o'clock. So enjoy your meal and thank you.